Thank you very much, Dr. Azam, Dr. Rahman, Dr. Mir Jamaluddin, and the great professors, Dr. Malik as well. It's my great pleasure to join with you today. I have no disclosures. So let me start off with the 60-year-old man with hypertension, cardiac arrest at home, return of spontaneous circulation after one round of AP and CPR, and pH is 7.2. As Dr. Henry showed, this is another EKG that shows the diffuse ST depressions, AVR, lead AVL, ST elevations. And what is the next best step? I think cardiac cath, medical therapy, hypothermia, and probably all of the above are correct answers depending upon the patient's neurological status. So he went for a cardiac cath, and here is there's a complete occlusion of the proximal LAD, as well as a very small circumflex branch, and but RCA has significant lesions as well. So now what should we do? You look at this LV gram, and it is really very severely LV systolic dysfunction. It can be seen, and the EF is about 30%. Balloon pump, impeller, ECMO, all of the above, none, just inotropes. Any of these answers may be correct depending upon which study you want to quote and move towards that. So in our center we have impeller, so we put an impeller in, we opened up that proximal LAD, and that has at least a TIMI3 flow in the LAD, and the RCA also was intervened. And as you can see that this patient remained in cardiogenic shock. And in follow-up, however, patient remained hypotensive on impeller, so VA ECMO was placed, and then he was given high dose DOPA, AP, NOR-AP, amiodarone, and he developed renal failure, remained acidotic, developed ischemic leg from the ECMO, transferred for heart transplant, and at the transplant center he was re-evaluated and made comfort care, and he died 3 days after cardiac arrest. So this is another patient, 47-year-old woman, diabetes, antiphospholipid antibody syndrome on rivaroxaban, came in with anterolateral MI, loaded with ticagrelor, primary angioplasty was done, LAD stent, and the TIMI3 flow was established. However, 1 hour later, VFib arrest, refractory to DC shocks, and ongoing CPR and Lucas, the autopulse, was initiated and brought to the cath lab back. And here you can see LAD is completely occluded, the heart is barely moving, there is no flow in the coronaries. So multiple shocks, VFib, then agono, asystole, and Lucas was positioned, and patient then underwent ECMO, and you can see the flow is being established with balloon angioplasty, and the stent which was there, it looks under deployed. And so that was post dilated a little bit, and TIMI3 flow, 2 to 3 flow was established. Poor flows on ECMO, the venous cannula was repositioned, and here's the clinical progress from day 1 to 22, but she survived. No or minimal contractility on echo, and day 2 she developed acute kidney injury, liver injury, and some contractility was noted on day 3. She was decannulated on day 5 and then transferred to balloon pump, and some distal embolic events were noted in the foot, and day 22 she was discharged with full neurologic recovery, LV function improved to 40%. So I think these two patients are slightly different. One came in from home as a cardiac arrest, the other one actually post MI went into cardiac arrest after 1 hour. So the definition of cardiogenic shock is always difficult in certain states, but the SKY made now with the multiple disciplinaries coming together, they finalized the diagnosis. Persistent systolic blood pressure less than 90, not responding to fluid administration alone, secondary to cardiac dysfunction, associated with signs of hypoperfusion with a cardiac index less than 2.2 liters per minute per square meter, and a wedge more than 15 millimeters of mercury. But however, shock is variable depending upon the studies that you look at. IMPRESS trial had actually majority of them are cardiac arrest, 90% of cardiac arrest patients, and lactate is between 7 to 8, and the pH is 7.1 to 7.2. Balloon pump shock 2 trial actually had lactate is only more than 2, and many of them did not have any cardiac arrest at all, and signs of hypoperfusion were noted. So obviously one size does not fit all. We need to have a common language, and hence the SKY stages of cardiogenic shock actually made it simpler for us to come to a common phrase that we use. So people can be at risk for cardiogenic shock with anybody with hypertension, cardiac disease, prior MI, all of them are at risk for secondary infarction and cardiogenic shock. But this first is a beginning of cardiogenic shock where the people start actually relative hypotension or tachycardia without hyperperfusion. Identifying the patients at this point of time and maybe using inotropes might help at this stage. And but in stage C, D and E shock, which is classic deteriorating or extremis, meaning cardiac arrest patients, or as I showed you, and all of these can actually get a modifier of cardiac arrest as shown here, that actually makes the outcomes worse. So as we go from C to E, the mortality increases, and the number of devices that we use also increase, the number of medications that we use also increase. So the most important clinical findings, as you see in D shock, they are already cold, clammy, and it's very difficult to maintain their perfusion. And in extremis, obviously they are requiring multiple devices and such as Impella and ECMO or something. Maybe there is a use for balloon pump on stage B or C, early C shock, I don't, so I think this is where people say that the balloon pump is of no use, or Impella is of no use, or ECMO is of no use, but where is the patient in this pyramid is very important. However, the therapeutic goal of acute MI and cardiogenic shock are stabilizing the patient, and number 2 is actually reperfuse the patient as soon as possible and minimize stunning. However, we can do that, whether it is stopping myocardial injury, restoring the normal myocardial metabolism, reperfusion injury can be prevented, and enhancing myocyte recovery. So this is a mechanical unloading and infarct size. If you do an unload with any sort of mechanical circulatory support, the infarct size can come down from 50% or 56% to about 28% as seen in this clear pictures. The pulmonary artery catheter by this Dr. Gidwani's paper, everybody said initially that there is no use of PA catheter, but it has been shown that it is definitely indicated in patients with cardiogenic shock during supportive therapy, and indicated in patients with discordant right and left ventricular failure and chronic heart failure. So there is definitely a need. And why is LV load bad? Meaning if there is elevated end diastolic pressure, as you can see here, the cumulative mortality can be about 8% or so in the same group of STEMI population. But if they don't have EDP, if EDP is less than 12, the mortality comes down to about 2.5 to 3%, which is significant. And so who are the patients who should be given acute mechanical circulatory support? Is anybody with cardiogenic acute ST elevation MI and cardiogenic shock may benefit to have a pre-PCI Impella in this National Cardiogenic Shock Initiative looked at it, and if you put a Impella prior to PCI, your survival is about 70% compared to maybe about 45% with the post-PCI Impella. So definitely there is an improvement in that trial. But then shock confused us, saying that immediate multi-vessel PCI carries a higher mortality to 55 compared to culprit lesion alone PCI. So all cause mortality is given here, 51% in the immediate multi-vessel PCI, culprit lesion only PCI is 43% at 30 days. And so this made the guidelines in European cardio ESC STEMI guidelines moved from 2017 2A to class 3. So the immediate multi-vessel PCI is not recommended by European Society of Cardiology. Even 1 year, the mortality is still in favor of culprit lesion only PCI actually. But you look at the repeat revascularizations, they are much higher at 32.3% in culprit lesion only PCI as compared to immediate multi-vessel PCI. So even though they do not need a PCI at the time, later on they might have needed it. In the national national CSI algorithm from United States, looking at about 80 centers from 29 states and enrolling about 400 patients, and rapid identification of cardiogenic shock, cath lab activation, femoral access, confirm acute MI and cardiogenic shock, and with the left heart cath, right heart cath, echocardiogram as needed to confirm the diagnosis, and placing a mechanical circulatory support. The whole strategy is depending upon door to support time with a target of less than 90 minutes, not to door to balloon time. So, the mechanical circulatory support, once it is placed, then you proceed with PCI, and based on right heart cath, whether you need a LV support or RV support can be determined based on the PAPI pressures as well. And once, if it is a cardiac power output is more than 0.6, continue to titrate down the pressors and inotropes. So, with this type of definite algorithm, they showed that actually in all cardiogenic shock patients, C, D and E were included. At 71% of the patients were able to be discharged, and definitely 53% has remained to survive at 1 year as well. So, and how does this National Cardiogenic Shock Initiative from United States compare to other trials here? Let's take culprit shock, which is here. In culprit shock, actually 54% of them are cardiac arrest, and 46% of them are cardiac arrest in National Cardiogenic Shock Initiative. And the 30-day survival in culprit shock was only 49%, whereas 68% survived in National Cardiogenic Shock Initiative. So, the DANGER trial, which is the Danish-German cardiogenic shock trial, is still ongoing. We will wait for those results. So, at 30-day survival rates from 2 decades of cardiogenic shock trials showed that compared to that, National Cardiogenic Shock C and D and all comers did much better than IABP shock 2 trials, culprit shock trials, or medical therapy in the shock trial itself. So, from the National Cardiogenic Shock Initiative is the largest prospective North American cardiogenic shock study in the past 2 decades, recruited the sickest cohort and who are unlikely to be recruited into any randomized controlled trial. Still, the survival of 77% at 30 days was much better in the stage C and D shock. And obviously, these patients did not have unfortunately did not have a survival up to 1 year, which is not really great, but that tells us that maybe guideline directed medical therapy is still required in these patients, and further randomized controlled trials such as Recover 4 is ongoing currently in the United States. So, in summary, patients with acute myocardial infarction and cardiogenic shock, culprit lesion only PCI with possible staged revascularization compared with immediate multivessel PCI is associated with a reduction in all-cause death or renal replacement therapy at 30 days as shown in culprit shock trial. This effect in the composite endpoint is persistently observed at 12 months follow-up. So, the 30-day difference in all-cause mortality is attenuated over time. However, there is no increase in mortality after 30 days until 1 year follow-up. So, right now I think culprit lesion only PCI at the time of cardiogenic shock is a good strategy, followed by pre-discharge PCI of the non-culprit vessels is probably the best strategy for these patients. So, I think in dealing with advanced cardiogenic shock patients in the current era of mechanical circulatory support, an appropriate device and patient selection algorithm should be applied to improve clinical outcomes and optimize utilization of resources in your particular institutions. If you do not have impeller, please use balloon pump and ECMO. I don't think that there's anything wrong with that. I don't think we can just say that okay, you don't know how to use, but you still have to use is something I think foolish to recommend. So, use the resources available to you. Thank you very much. I'll stop here.